Okay, so in this second lecture, we are going to talk about hypovolemic shock, neurogenic shock, cardiogenic shock, and psychogenic shock. So we're going to start with hypovolemic shock. So hypovolemic shock is when blood volume is actually leaving the vasculature. And there are 4 subdivisions, which we are going to talk about in the next few slides. So it's important to know that our normal blood volume, we're going to put BV for blood volume, is 4 to 6 liters in an adult. And a loss greater than 1/5 of that is going to result or could result in hypovolemic shock. So there are 4 subdivisions of hypovolemic shock. The first being hemorrhagic shock. So the definition is hemorrhagic shock is acute blood loss, so sudden blood loss without soft tissue damage. So this would be a GI bleed, a rupture of esophageal varices, so something that's not traumatic. So let's write some of those examples down. So a GI bleed, like a lower GI bleed, rupture of varices would be another example. Varices. So something that has no soft tissue damage. Ruptures of capillaries, so DIC would be an example of a hemorrhagic shock. The second subdivision is going to be traumatic hemorrhagic. The key word here is it's an acute hemorrhage or blood loss with soft tissue damage. So this is going to be things like, excuse me, this is going to be things like a car accident. So trauma from an MVA, penetrating wound, so gunshots, stabbings, anything that's going to have soft tissue damage. This is when you're going to see blood on the trauma room floor. The third subdivision is going to be hypovolemic shock. And so this is going to be a critical reduction in plasma without hemorrhage. So fluid is still leaving the vasculature system. And this is where in the previous video, we looked at that wheel, that image on the last slide. And we have shocks that kind of start to overlap. So this is going to be towards the distributive side. But an example here would be a saltwater drowning. So saltwater drowning. So traumatic hypovolemia is going to be again, it's a critical reduction in plasma, but they're also going to have either a hemorrhage or they're releasing inflammation mediators. So they're causing more swelling. So an example of this is going to be a crush injury. And a crush injury is an injury that happens, for example, when somebody is pinned between like a rock and a car or in between 2 rocks, and there's a lot of pressure coming to that area of the body that is crushed. We have obstruction of blood flow to that area. So we have the vasculature is now dilating. So we're losing plasma. And then we have inflammation mediators being released because of this injury. Or if the vasculature is hemorrhaging internally as a result, we would have a traumatic hypovolemia. So the takeaways that's going to help you remember the difference is if it has traumatic, that means we have an actual loss of blood. with soft tissue damage. Okay, so hypovolemic shock is because we don't have enough volume. So this is going to be an absolute shock. There's not enough oxygen being carried to the tissues because there's not enough blood cells for the oxygen to attach to. So then we're going to have a decreased organ perfusion. So that means that our heart and our lungs are losing circulation first, and they need constant circulation. So we're going to start to see some organ failure. Hypovolemic shock can be an external loss of blood, so we're actually seeing it. It can be internal, so an internal bleed, or it can be a loss of plasma. If we lose 20% of our blood volume, that's going to result in shock and death pretty quickly. So we want to replace our volume ASAP. We can replace it with saline. We can use plasma. We can use whole blood and packed red blood cells. We can use lactated ringers. We just need to make sure that we're replacing this so that we're giving our body a chance to compensate and be perfusing our organs. But it can happen, shock can happen as little as 800 mLs are lost. So a loss of 800 mLs can lead to shock, and even less for smaller patients and pediatrics. So symptoms of hypovolemia, a lot of these are like the general causes that we talked about in the previous video. So a rapid thready pulse. So especially during the compensation phase, our heart is trying to go faster. It's trying to compensate. The body wants to send oxygen to the site of injury to start healing itself. It's going to be thready because we're losing that volume. So it's not going to be consistent volume. And then eventually that can lead to a failure of the heart. So then we have another type of shock, okay? Tachypnea, again, we're trying to compensate. Altered level of consciousness, anxiety. So you can have some shocks are going to be worse than other types of shock or situations, right? The body can go into shock and have the same symptoms, and sometimes it's going to present worse than other times. Restlessness, confusion, and unconsciousness. So unconsciousness, that's when, the brain is saying, hey, I'm just going to focus on breathing and beating the heart and trying to heal. We're going to take everything else away because I cannot function properly at this time. And then cool, clammy skin. The body's shunting the blood to the core, to those vital organs. Weakness, pallor, hypotension, and decreased urine output. So again, those are the same as the general types, but the cardinal symptom is going to be hypotension because we're losing that volume. Okay, because if we have a decreased cardiac output, we're going to have hypoxia. And because we're hypoxic and our organs are not perfusing, and there's going to be lots of waste, our ABG is going to be a metabolic acidosis. So let's talk a minute specifically about a traumatic hemorrhage. Remember, so this has soft tissue involvement with the hemorrhage. So we're going to have coagulation is going to be imperative. So applying pressure and number one, determine where the hemorrhage is coming from. And then number two, applying a direct pressure to that area to start the clotting process. and then our body is going to release those inflammation mediators. So once the inflammation mediators are sent out, we have that vasodilation and we can increase vascular permeability. The sympathetic nervous system is going to play to compensate, right? So the early response in the sympathetic nervous system are going to be tachycardia, tachypnea, increased blood pressure, which again may give us that false sense of hemodynamic stability. But this patient can crash quickly, so it needs to be treated with direct pressure and treating the cause, as well as maintaining volumes and fluid replacement. So tachycardia is going to increase cardiac output. And remember, cardiac output is stroke volume times heart rate. So our body is compensating with the heart rate because our stroke volume is going to start decreasing with that fluid loss. And it's doing this because we want to increase oxygen to the site of injury. That is our body's response. We want to heal it. But our body can be its own worst enemy because if we increase cardiac output, we can hemorrhage faster. So fluid replacement, finding the wound, and correcting that hemorrhage. Okay, the case in this picture here, this would be an example of a traumatic hemorrhage. This is a construction worker, and he fell off a third-story building and landed on rebar. He lost a kidney, had bowel perforation, but he did end up surviving. So treating hypovolemic shock. The first thing we want to do is treat with fluids. And with fluids, we want to treat with crystalloids. We have lactated ringers. We can treat with albumin. Albumin is a protein that your body naturally makes, but remember, it's in the plasma, and it's going to work with the osmotic pressure to kind of pull that fluid back that has been third spacing back into the vasculature to help improve our blood pressure. We can treat with whole blood as well, and saline. So fluid replacement is going to be imperative. We can do intubation for oxygenation, medication. So the big ones here are going to be pressors. And pressors are going to cause vasoconstriction and help increase our blood pressure. We definitely want to do cardiac monitoring. CVP, so central venous pressure. If needed, we can do a pulmonary artery pressure, a PAP, which is a Swan-Ganz, and they're going to need to be on telemetry. We need to make sure that we are monitoring these patients in the ICU and in the emergency room. The shock position, so that would be in the field, or if you witness this outside the hospital. The number one thing that we want to do is control bleed, and determine where it's at. And the underlying condition. So some complications that would happen if we do not treat this type of shock. Yes, death if it hasn't happened yet. So if we're not controlling that bleed, then that's going to result in death, right? If there's no blood in the system, the body is not going to survive. We're going to have metabolic acidosis, but first we're going to have a respiratory alkalosis. Remember, it's the body's response for tachypnea, and during that compensation phase, we're blowing off all of our CO2, which is going to result in a respiratory alkalosis early. So this is going to be early. And as we have cellular death, then we're going to go to a metabolic acidosis. Kidney damage, kidneys need to be perfused. They can be wimpy. And then if our body has a lot of waste, then we're worried about, excuse me, the kidneys overworking and not having enough nephrons to process all of that waste. Cardiac and cerebral ischemia can happen due to that lack of perfusion. We just don't have the oxygen that is circulating because we don't have the carrying capacity because we're losing the volume. So takeaways from hypovolemic shock. Know the 4 subdivisions, understand the body's response, and how to treat it. Okay, neurogenic shock. So when we talk about this, Frank Starling's law is in play, and changes in venous return will directly affect stroke volume. So that's our preload. Our preload is going to affect our stroke volume because if there's no blood in the left ventricle to pump to the heart, then that's going to decrease our cardiac output. So neurogenic shock, which is a relative hypovolemia, is going to occur when there is an injury to the spine and or the brain, okay? So it could be one or the other, both. And it's because there is a disconnect or imbalance between the sympathetic and the parasympathetic nervous system. And remember that the parasympathetic nervous system rest and digest, and the sympathetic fight or flight. So you can see where if there's an imbalance and one is more in charge than the other. Parasympathetic, we cannot live without the parasympathetic nervous system. So the vasodilation, digestion, slow, shallow breathing, it's going to have a decrease in blood pressure. The sympathetic nervous system we can live without. And that's, remember, we're going to have vasoconstriction. It's going to increase heart rate. We're going to take big, deep breaths. We're going to have vasoconstriction, so increased blood pressure. So what happens with neurogenic shock is our centers for circulation regulation are affected. So this would be our heart and our vascular smooth muscle. So our pump and our blood pressure are going to be affected because we have altered afferent signals. So remember, afferent means signals that arrive at the brain. So our medulla oblongata, which is going to control our fear, our stress, our pain, it's going to send that message. It's going to process that afferent signal. It's going to send the efferent signal, the exit signal, out for that response for the cardiac action and the vascular smooth muscle. So the signals are affected arriving to the brain. And then we have an interruption in the descending connection. And we'll go through this on an image in the next slide as well to kind of reapply this information. So those messages from the regulatory centers that go to the spinal cord are being interrupted. So going from the brain to the spinal cord. And this is especially going to affect those who have an injury direct, like TBI, or from the middle of the thoracic spine and above. Okay, so some of these may be cerebral ischemia, so a loss of oxygen and tissue death in the brain, subarachnoid hemorrhage, meningitis, Guillain-Barré, myasthenia gravis. So anything that's going to affect the central nervous system. And so, as you can tell, Guillain-Barré can be temporary, right? Meningitis. So once we treat the cause, that can be reversed. Neurogenic shock can be reversed. If you have permanent damage, and you can see this in patients sometimes with Craig, when they have a spinal cord injury, they may go in and out and have blood pressure changes consistently. So I put those examples down at the bottom for you. Cerebral ischemia, subarachnoid hemorrhage, meningitis, Guillain-Barré, spinal cord injuries are all going to be causes of neurogenic shock. So this is the image that I was speaking about. So our afferent signals are going to come from our baroreceptors in the aortic arch and the carotid sinus. So those are going to tell us we need to change, right? With our movement, we need to change this blood pressure, and we need to send that message to the brain. It's going to arrive at the brain in the hypothalamus medulla oblongata. And then the brain needs to process that. So if we have damage here as well, that can affect this and cause neurogenic shock. Think of POTS, that would be an example as well. And then there's some disconnect as it goes to the spinal cord to send our message to the vagus nerve to the heart for beat and squeeze, and then out to our smooth muscle on our vasculature, okay? So there's a disconnect from afferent to efferent. That's what I want you to know, is there's a disconnect from the afferent to efferent signals that is causing the fluctuation in blood pressure. So it's critical to treat the cause. We have to treat the cause. And sometimes it may not be fully reversed if there's a permanent damage, but like Guillain-Barré, meningitis, if there's a brain bleed that is causing the brain to swell and there's going to be a decrease in oxygenation, that's going to disrupt the signal from the brain to the spinal cord. So those efferent signals. So treating the cause is going to be first. Rapid fluid replacement. So it's massive vasodilation. So it's our body's not able with those baroreceptors to change the blood pressure and send that signal. So we want to make sure that we're replacing fluid. We can increase norepinephrine because that's going to increase our systemic vascular resistance, right? Because it's going to cause vasoconstriction. And that increases our systemic vascular resistance, which increases blood pressure. Sympathomimetics, so epinephrine, dopamine, and other inotropic agents. So inotropic means it's going to help improve the squeeze of the heart. So we're going to increase our cardiac output because we're going to increase our stroke volume. Okay, so psychogenic shock is going to be another relative shock process. So psychogenic shock is also known as syncope or fainting. And it's usually caused by extreme emotions, right? So fear, bad news, sight of blood, and it's rapid vasodilation. So all of a sudden, the baroreceptors don't have time to respond. We have rapid vasodilation, then our blood pressure is going to go down quickly, and that's going to cause unconsciousness. And we have a sudden loss of blood to the tissues, that's what's causing the unconsciousness. So to treat this, the biggest issue is going to be secondary injury. So this is the biggest issue. Falling and injuring one's head. It's typically self-correcting unless there's a second injury, right? So if we fall, we hit our head, and that causes another injury. But most of the time, it's self-correcting if it's a one-time thing. Now, you'll hear of syncopal episodes or episodes of fainting. That's when we need to look at this syncope algorithm that's on the next slide. So if it's not an isolated event and it continues to occur, that's when we start to worry and we start to think about treating an underlying cause. Okay. So I'm not going to ask you to rewrite or memorize this algorithm. I just want you to know what is going to happen with your patients who have continual episodes of syncope, so we can get a diagnosis. So the first thing they're going to do is they're going to take a history, and this is going to be done usually by a cardiologist or a neurologist. It can start in the emergency room and then referring to specialists. So we can have a physical exam and an ECG. And then if we know for sure that there's something abnormal, we're going to treat that. But if we can't figure it out, if there's no diagnosis, but there is an abnormal ECG, so there's a not a normal heart rhythm, or an SHD. And SHD is a structural heart disease. So that means we find something abnormal, and then maybe we do an echo, and we see that there's an abnormal tissue in the heart. Then we would send them to a cardiologist to get that echo, maybe do an exercise stress test, do a TTT, which is a tilt table test, and that's looking at our baroreceptors functioning properly. So this is going to say, is it a cardiac issue? If those are all normal, but they have frequent symptoms, then we can still do a tilt table test. We can do an implantable loop recorder. So that's a device where they would implant it to do continuous monitoring of the heart for 14 months. And that we can do a Holter monitor as well if we want to do something that's only 24 hours. So it's just going to be varied based on the physician and how severe the symptoms are. So cardiogenic shock. So this is going to be a problem with the heart itself. So cardiogenic shock is pump failure. Our heart isn't working, and it's the heart's fault. So in this study that we are referring to here, we're going to say systolic arterial pressure less than 90 millimeters of mercury, or a MAP less than 30 millimeters of mercury below baseline is going to tell us we're in cardiogenic shock. Okay. So normal MAP is 80 to 100. A MAP less than 60, we stop perfusing our organs. So if our patient has a baseline MAP of 90 and they are at 60 millimeters of mercury for their MAP, they're in trouble. That's when we know they're going into cardiogenic shock. Okay. Along with that, they need to have evidence of cardio dysfunction. Okay, so some causes of cardiogenic shock. So myocardial infarctions can be a cause, acute coronary syndrome, and typically those can be a preemptive cause to cardiogenic shock. The more times that a person has acute coronary syndrome and they continue a lifestyle, they're going to be more likely to go to cardiogenic shock. 20% of people with acute MIs can develop cardiogenic shock, or will develop, I should say. So 20% of MIs will develop cardiogenic shock, where the heart stops working. Cardiac myopathies, myocarditis, pharmacological toxicities, so heart meds that work the heart too hard, or drugs that are taken that work the heart harder that aren't treated properly, can cause cardiogenic shock. Street drugs, especially stimulants, can cause cardiogenic shock. Blunt trauma can also cause cardiogenic shock. Okay. Rhythmologic. So this is going to be the electrical conductivity of the heart. So something that's affecting the rhythm. So bradycardia, such as heart blocks, can cause cardiogenic shock because the heart is being starved for oxygen and it's not a perfusing rhythm. And then mechanical. So that would be that blunt trauma, anything that's going to physically damage the muscle of the heart. Okay. Symptoms of cardiogenic shock. So a rapid thready pulse, tachypnea, altered level of consciousness, right? We're not perfusing our brain, and that's going to alter our level of consciousness. Diaphoresis, pale pallor. Poor cap refill. Remember, less than 2 seconds is normal, okay? Greater than 3 to 5 seconds, then we're going to start worrying, okay? Pulmonary edema. It's a pump problem. The pump can squeeze out. The fluid needs somewhere to go. So we can see pulmonary edema on our chest x-rays. Okay, to treat cardiogenic shock. So we're going to diagnose with an echo, or we're also going to place invasive monitoring. So a CBP, and that's going to tell us our overall fluid status, what's returning to the heart, and then a pulmonary artery pressure line, which is a Swan-Ganz. Not always, we don't see them very often, but when you do see them, they're more than likely going to be in the cardiac ICU. We're going to have reperfusion therapy. So an interaortic balloon pump, and we can also do an Impella, an angioplasty or a CABG, so coronary artery bypass graft. A very bare minimum for an MI is we're going to place a stent. So we're going to open up that vessel so that we can get blood flowing back through the vessel and to the heart to prevent further tissue damage. So medication, so no Mona. Mona is morphine, oxygen, nitroglycerin, and aspirin. We'll talk about those more specifically when we talk about ACLS. But nitroglycerin is a vasodilator. So again, we're going to dilate those vessels so we can get more blood flow. So hopefully we can improve oxygenation. Aspirin is going to help prevent further clots by making those platelets not stick together to start the clotting process. Antiarrhythmics, if that's necessary, we're going to try and get that rhythm back on track. So if we have SVT, for example, we're going to give adenosine because SVT, we cannot stay in that rhythm. It will not be perfusing. And then vasodilators. And with vasodilators, we want to systemically vasodilate because we want to decrease how hard the heart has to pump against systemic vascular resistance. So that pressure that it has to pump against, the afterload, we want to make sure that it doesn't have to overwork and work too hard. When treating cardiogenic shock, no fluids, no fluid. If they have a low blood pressure, they're hypotensive, they've gotten out of that compensation phase, then you need to use medications to increase blood pressure. So pressors, vasopressors, because fluid is going to make the heart work harder. So it's not a vasculature issue. All our blood volume is there. It's a heart issue. And if we make our heart work harder, then its metabolic needs are going to increase even more, and we're going to go to the refractory stage. So this is an intra-aortic balloon pump. So in diastole, when the heart is relaxing, our balloon is going to inflate, and that's going to help support and rest the heart so that it doesn't have to squeeze as hard when we have systole. So it's going to decrease ventricle workload and increase cardiac output. And we will watch a video of how it works in class. Okay, so takeaways before the next video. I want you to make sure that you understand how you can treat each specific cause, physiologically what is happening with each specific cause, and then how you identify each specific cause.